Hello, everyone. Thank you very much for coming today. This is a really interesting conference. It's nice to be at something that's kind of different. Often they're very similar, these conferences. This is a nice, different spin on the healthcare IT world. And my panel that I'm going to moderate today is called Consumer Access to Healthcare Data. You're going to see representatives from a few different organizations that are deeply entrenched in those areas. But I wanted to start out by saying that, according to conventional wisdom, improved access to healthcare data, makes better informed patients, better informed providers, better informed outcomes. And we talk about data sharing with patients these days like it's the holy grail in the healthcare system that will make it responsive and effective. But let's face it, most of us are inundated with data all of the time. And very few of us know how to integrate all of that data into our daily lives to make decisions. Few of us really want to know how many steps we've taken in a given day, or how much of our body is made up of Snickers bars or beer. And even fewer of us really are willing to make the hard decisions to trade off convenience for comfort, or comfort for cost and quality. It's a very difficult dynamic, particularly when you also add in factors like privacy, et cetera. Furthermore, big data is sort of the whole rage right now, what everybody's talking about. But really on the consumer front, consumers mostly care about little data. What matters to me in this moment, right now, to make me feel better. And the data that's bigger than that is often too complex and incomprehensible for consumers. So how do we take data and use it for consumers to make it useful and to make it important enough for them to want to engage with the healthcare system? I think as we transition from a system where the health providers and the health payers are not the center of the universe quite as much as they have been, one where the consumers are buying their insurance, for instance, from exchanges, or otherwise engaging and making more choices as the purchasing unit. Everybody's trying to figure out how you take all that data and make it actionable and use it to reduce costs in particular. And there's a general sense that if only you could figure out the magic formula to doing that, angels will sing and unicorns will fly and all the rest. Today, the panelists that we have will discuss how their organizations have found ways to use data with consumers to engage them actively in the healthcare system, how the industry, theirs and others, are using big data and little data to benefit the consumers, and also talk about what's needed to make the system and the data collection and utilization process more consumer-focused and more accountable in order to improve outcomes. So, folks, if you could come on out. I'll start by having the panelists come on the stage here. This is Jill Yegian from Integrated Healthcare Associates, Martin Watson from SeaChange Health, and Kathy Marco from Castlight Health. And perhaps we could just start by having each of you take a moment, just a quick moment, to introduce yourselves and your backgrounds. Jill, you want to start?
Sure. I'm Jill Yegian. I'm with the Integrated Healthcare Association, but I have been at IHA for a week. So today, I will actually be talking from the perspective of a researcher. And I came most recently from the American Institutes for Research. My background is in health services and policy analysis, and I have a particular expertise in health insurance and health insurance markets and how people make decisions.
Hi, I'm Martin Watson. I'm a founder and CEO for SeaChange Health Insurance and SeaChange Health Solutions. So we're a startup health insurance company in California and Colorado. And we also have a software play that provides our analytics and services to both our own insurance company, but also other payers, and starting to move into other self-funded companies. Our growth is pretty good. We're focused on only marketing value-based insurance products and services, and we're expanding rapidly.
Speaking of expanding rapidly, I'm Kathy Marco from Castlight Health. My early career was in healthcare IT, working with a number of vendors, more in the transaction processing, so practice management system development, as well as managed care system administration. So have this broad knowledge of the healthcare data set, and got quickly frustrated that there was this wealth of data and not really being used beyond managing the financial transactions, and had an opportunity to work for Pacific Business Group on health to manage the California collaborative doing performance measurement and reporting. Some of you may be familiar with the patient assessment survey that IHA uses as part of their pay-for-performance program, some of the work done in really trying to develop methods for doing physician-level performance measurement. That led me to Castlight, where we're really working to make that information usable by consumers. So really bringing information to consumers to make them smart healthcare consumers.
Great. Well, we're going to have each of the panelists give a brief presentation, and then we'll do Q&A. So Jill, I believe you're first.
So I wanted to just begin by acknowledging the California Healthcare Foundation, which sponsored the research that I'm going to report on in terms of just sharing a few of the high-level findings. And I wanted to begin with just a little snapshot of how I think people make decisions with whatever information they have. The choice of a provider, of a physician, a primary care doctor, or a specialist is critical to the care. That's really your gateway to the healthcare system. But we really don't have information to inform that decision that looks anything like most of the other sectors in which consumers make decisions. So it's quite feasible that you could actually be making a decision based on whether your doctor has more friends on Facebook or is retweeting your message. And of course, this cartoon also speaks to the growing influence of social media. Because I have just very little time, I'm just going to hit a few key takeaways from the work that we did, which was really intended to capture the demand for and use of cost and quality information for decision-making by consumers. And one of the key takeaways that we arrived at as a result of this project is what I'm calling here, it's all about me. And really the point that I wanted to make here is that the consumer lens on quality and cost information is important, and it's also really distinct from a number of other stakeholder lenses which are often thought about with respect to cost and quality data in the healthcare sector. So for example, a health plan, a provider, a policymaker, those are also important lenses, and they're really distinct from the consumer lens. For consumers, for example, individual level physician information is really important. And consumers want to know not about what medical groups' ratings are. They want to know about the ratings for their own docs. They don't really care that much about resource use across a community or about utilization rates for procedures. They want to know what their out-of-pocket cost is going to be. They want to know based on their deductible and their provider network and any kind of tiering and any kind of reference-based pricing and all that, summed up, what's it mean to me? And the integration of that cost and quality information is really important from a consumer perspective. And we know from research that when consumers have cost information and they don't have quality information, then they end up using cost as a proxy for quality. Another key takeaway that we captured was what I call help me understand. And here is really just to capture the notion that there's a very broad evidence of effective presentation of information, but it's inconsistently applied. So you can have fantastic data meticulously collected, and it really ends up falling completely flat if it's not presented in a way that consumers are really able to understand. And this is seriously underappreciated. Visual display is really important. A clean, simple formatting. Labeling is really important. Symbols are helpful, but using a word in conjunction with the symbol to help with interpretation is very important as well. And that's just sort of the tip of the iceberg as far as what's known about effective presentation. Contextual information, we all know there is an enormous overflowing amount of information. So whatever we can do to help people hook information, help them translate, understand, make it relevant. This might be anecdotes about patients like me. It might be really providing real-life examples of how people have used information to make decisions. And just wanted to highlight a couple of the implications. Our sense is that there will be more demand for cost and quality information, and one of the panelists in the last session noted the expectations that consumers are having that are really changing and increasing with respect to how immediate and how thorough their access to information is. Out of that, we anticipate growing tension between the rigor of public reporting and the practical approach of entrepreneurs. And in particular, the public reporting folks have traditionally been very much about science, about statistics and validity and sample size, and also the practical approach of entrepreneurs providing what data is available without respect necessarily to the quality and rigor of that information. And neither one is right, and it's important to acknowledge that tension. On the cost side, there will be more pressure for out-of-pocket cost data. Some of it is being provided by partnering with health plans that own that data, but some will happen potentially through regulation or all-payer claims databases, or also through new health insurance exchanges. And then we want to really make sure that consumers are engaged in that process. As a final note, I just want to note that the February 2013 issue of Health Affairs has an article that explains some of this in more detail than I can get to in this amount of time. And to note that I have a number of collaborators on this work at both American Institutes for Research and at the California Healthcare Foundation. So I'll look forward to the discussion.
Thanks, Jill. Martin? Oops.
Maya? Oh, great. Thanks. Okay, so I'll walk you through a little bit of the experience that we've had. We've currently got 1.2 million members on our solutions platform. This is where we're essentially helping other payers with their primarily value-based programs, which is trying to influence members to change their behaviors and using benefit design or some sort of incentive tied to their benefit design to get that engagement. One of the critical takeaways, obviously, is not just having a plan and an elegant or simple to understand incentive program, but it also is to get the end client or employer to really engage with the process and push it through. None of this is, terribly rocket science. The information, you want it to be frequent. We found that you need to have all modalities as far as what you do for engagement. We crank out, 1.3 million hard copy reports every quarter. We send out emails. We send out, we have personalized web pages and textual messages going over mobile. So you really need to do everything. And one of the things I'd like to see that we've seen in the past is that if you don't have participation, you basically, what I like to do say is you kind of got a dead cat bounce program, which is you kick off programs like Let's Do the Biggest Loser program, or they're going to focus on a smoking cessation program. There's lots of engagement, people get involved, and then it just craters and flatlines going forward. So you've really got to view it as something that needs consistent kicking or paddles to the heart. What we've seen on average for our plans, the members are asked to do 9 to 12 different things over the course of the year. And what you consistently see is that you do the communication. And one of the things we've found that really gets engagement around data and getting them to do the things you want them to do is the thought of that they're going to actually lose a benefit. We found that when you offer up, if you do these things, you'll get something, you get very low engagement. But when you tie it to, you have this reward sitting out there, and if you don't do this in X number of weeks, you're going to lose it, you see a sudden spike in participation. And then once that goal is achieved, then they go back to doing nothing. And then you reach out to them again and say, look, if you don't do so, you've got another $100 or $50 or whatever, and you need to complete it in 3 weeks, you see another spike. And it's just, so you definitely want to have the data and all the information in nice, easy to read formats, but you got to do the constant engagement and reminding them that they're going to lose something if they don't do that action. And then our belief is that we do things around basic things. For this example is health questionnaires, or whether it's biometric screenings or going to see your physician, that tying it to a tangible financial impact, whether it's what your out-of-pocket going to be for doing some shopping on procedures, or what they can get as far as reward with benefit design, is critical, and it has to be tied to, you have to have multiple types of incentives. So some folks really engage with shopping versus others that get into seeing benefits being readjusted. And again, the client helps drive that. So some of the results, we've had a steady cohort now of 500,000 folks for a few years, and we found that the programs where you're consistently reaching out via multiple means of communication, and the discussion of you're going to lose this reward really does result in pretty good compliance and engagement in the programs. Great, thanks.
Thanks, Martin. Kathy?
So at Castlight, we're actually living Jill's research and working to get my PowerPoint up. How many of you have a high deductible health plan where you're paying the first, say, 1,000 or more out of pocket for your health care? Oh, wow. We got a lucky group of people in here that have some pretty nice coverage. Not representative of the overall commercial population. Okay. So our mission at Castlight is really creating healthcare consumers. It's all about providing them with the information they need, the incentives they need to make smart healthcare choices. We have over now 4 million users nationwide. Our customers are some of the largest employers in the country that are self-insured and have high deductible health plans. So they're motivated to provide tools for their employees that help them make better healthcare choices, both in terms of cost and quality. And I think similar to what was just said, engagement rates, it's all about communication. It's about providing the incentives. We're able to get up to 70% for some of our employers where the eligible users are actually coming, registering, using the system, and demonstrate that we are changing behavior. And we do that through an integrated experience for the user. So we provide cost information, and it is what the consumer's out-of-pocket cost would be. So we have 3 years' worth of claims data, or 2 years, sorry, able to, in a sense, reverse engineer what the health plan contracted amount is. We have a record of and know where the consumer is in their accumulated benefits, and we can apply that to, say, for this provider, here's what your out-of-pocket cost is. We have some physician quality information, hospital quality information. We aggregate data from publicly available sources. We work with regional collaboratives around the country, similar to CCHRI in California, to bring that data to the consumer in a way that's actionable and digestible for them. We include educational information, how to get the most out of your health care. What is it that you need if you have diabetes? What should you be doing? What does the evidence say? The provider directories, we include not only medical but pharmacy support, and then links to provider programs. So if you're looking for hip replacement surgery and your employer, has a second opinion program, it's all in one integrated experience for the user. this is just to demonstrate one of our customers' experience in terms of really by having that integrated experience, they're able to get their households registered and actually coming back and using the system. Some people come back just to look at their claims history, paid claims. Others are looking for new care and new providers. The key is, and I think Jill outlined most of this, so I'm not going to spend a whole lot of time on it, but what we know in terms of price variation, California, one region, one plan, their contracts for a colonoscopy varies between roughly $500 and $4,000. People don't necessarily appreciate that. Quality similar, lack of correlation between cost and quality. The cost data is not alone. People will pick the highest cost provider often if you don't have other information to help them understand that there may be a difference. So in terms of the challenges and limitations, and this gets a little bit into the weeds, the data quality, just the provider directory information alone. We get hospital information that may have a billing address associated with the hospital, or a P.O. box. That doesn't help the consumer get to where they need to for care. The quality metrics that are available, we're really focused on performance improvement, which is great, but not terribly helpful for consumers. So it's what's being measured needs to be relevant to them, as well as the level of reporting. And Jill talked about physician level. They want to know that the provider takes care of patients like them, and it is about me. And we didn't even work together to come up with that concept. The level of consistency of information. There's US News and World Best Hospitals. There's Truven Top Hospitals. There's the Leapfrog Safety Score. None of them align. So what's a consumer supposed to do with that information? How do they pick the hospital that's right for them for the care that they need? I think someone earlier used the expression culture of constrained sharing. It's, again, this information, who owns the information needed to be able to do this? There are regional collaboratives that are doing great quality measurement, not often willing to make it more available to a broader audience outside of their websites. There are providers and plans that have agreements that disallow sharing of some of the information. We need to free all that up and really put it in the perspective of what do we need for our consumers.
Great. Thank you very much, Kathy. So let me start by asking you guys a question. You know, my belief is, and I'm sure most people would agree, that people are overwhelmed by data. The data's coming at you all over the place. And most of the time, consumers don't want data. There are going to be very discrete situations in time and amount and style when they do. When do they want it and when do they not want it? Martin, you want to start?
That's a good question. So I'm the oldest one on the panel here, so I'm kind of cynical. So when it comes to healthcare, I think a lot of people really are pretty disinterested in seeing the information about themselves until some sort of event has occurred. And my basic premise is that you really just need to have that data readily available for that moment in time when they're going to start engaging in it. And you just need to make it as easy and accessible as possible. But the expectation that there's not a big segment of society that are really active on engaging with that.
Did you want to ask something, Kathy?
What we found is often, you know, when the employer first launches Castlight, the users come to our site to check up on their PCP. So they want to see what information we have. They come back to you know, if they have a particular need, they need surgery, or they have a family member that needs health care. Or they may be just coming back to look at their paid claims data. And I think it's a combination of having the information available, having it at a level that they can use it, and then providing the incentives that sort of help engage them and get them to use it, whether it's a rewards program that says if you do this action, you get points and maybe contributions towards your health saving account. It could be, excuse me, I just lost my train of thought when I was choking.
There's probably some data that would help you with that.
Yeah. Or it could be, the rewards is a positive. It could be programs like reference-based pricing, where there's a capped amount that a health plan will pay for a particular service. Anything above it, the consumer is responsible for. That starts to educate them in the concept of cost variation and really shopping for health care.
So Jill, you mentioned a topic that was near and dear to my heart, which is the language of healthcare and how complex it is for people. And the average person, I mean, we've got a room full of healthcare people here, and people are asking about the meaning of acronyms. Just imagine the average consumer. What measures need to be taken to make data comprehensible to consumers? And what are the best example and the worst example you've seen of this?
That's a great question. And a little bit politically charged one. There are some measures, I think, that are happening, and I guess I'd like to just distinguish briefly up front between the world of quality and cost information for decision-making about choosing providers and obtaining services versus health insurance. And they're related, obviously, but the world of insurance is a whole separate world of very complex and difficult terminology, and you get into all of the co-insurance and the deductible and the exclusions and the used-to-be pre-existing conditions, soon-to-be not. And that is an area where, under the ACA, there are new disclosures that are intended to be standardized and simplified. There's a little bit of a distinct issue around the reporting of clinical data, for example, in terms of quality metrics that Kathy talked a little bit about. And that's a distinct hurdle. And there it's a combination of both trying to explain, for example, readmissions, explain that in simple language so that people understand what it is, and then also making it matter. So helping people understand this readmission isn't something that's just about someone has to pay more, and so I don't care about that. That's what my insurance's job is. But rather making clear why a readmission is often preventable and a signal of quality. And so helping people understand those things. And there isn't any sort of silver bullet to that. It's really dissecting each of those, from my perspective, it's first prioritizing what's most important for people to understand, and then simplifying it and making sure that the delivery of the information is well tested, and then is updated over time as circumstances change.
So what's the best example? If you can think of something, an application or a program or a product that you've seen where they've done a really good job communicating to consumers? Besides Martin's, of course.
Well, I actually think that I know
Gaslight.
Kathy's better than Martin's, and I actually like Kathy's a lot. And then there's, of course, this distinct issue between the data that powers the interface and the interface itself. And Kathy is very articulate about the limitations of the data that power it, as well as their advantages. But the interface itself is a very nice, understandable, integrated access to cost and quality information.
Okay. So can I?
Yeah, jump in.
So there's almost a little bit of a flip that I think we're on the cusp of, and it's all around this, the big data and what's out there. But it's not just the access to the data, because consumers can access terabytes of data. I think we're starting to just now penetrate, and we're working with some very cool behavioral economists, of looking at the data down on segments, banding, what your age, what your gender, what your ethnicity, what type of plan design you're in, where do you live, what's the costing data, and starting to not just be retrospective, which is what we've been up to now, right? Which is you get claim data, you crunch the data, whatever it is, and you say, this is what happened. But now taking the data and looking at it down to that individual level and doing a prospective and then trying to reach out to that consumer and say, here's some information that you may find of value, not for yesterday, but of tomorrow, which is, you know, what you guys essentially provide. But I think we've got now just starting to drill down, because our industry is inherently, you know, behind the times, of figuring out what's going to be compelling for that person to get them to do something and accessing that data.
I also just one small thing to tie onto that. I think it is really important to think strategically about what those windows of opportunity are, where people are going to care, and try to build on those rather than try to convince people they should care about things they don't inherently really care about. And so CHCF actually uses this term shoppable conditions. And there are things like maternity. People care a lot. Pretty much every woman who gets pregnant is going to care about making sure that she's chooses a good OB, finds a good hospital, gets the care she needs. And so that's one of those shoppable windows of opportunity where people really are likely to do research and to care about the results. And so segmenting the population and really identifying those opportunities can be a really helpful way, rather than kind of banging away at the entire population.
And just to build on that, it really is about personalization and the individual's preferences. Some people might want a primary care doc that's really close to their office, so convenience becomes a factor. Quality, in some cases, it may be, if I'm looking for a primary care doc, I want one that I can actually have a good relationship with. If, however, I'm looking for some kind of surgery, I'm less concerned about the relationship with the doctor. I'm more concerned about the outcomes and whether the surgery is going to be effective for me. So it's being able to let the user get the information and help them get it based on what their priorities are, what their needs are at that time, and they will change over time.
So let's be real. Providers and payers, they don't like to share data with customers for the most part, consumers. They don't want to. They often view it as their proprietary information that keeps those customers in their clutches forever. So why, in this case, and I'll start with you, Martin, why should payers and providers be happy to share their data with consumers? What are the reasons that should be good for their business?
Well, payers, I think, have always had a desire to share information. It's just that the legacy contracts that have been entered into have put up a pretty good hurdle against being able to do that.
Spoken like a true payer. Nicely done.
Yeah. You know, but the payers have done a horrible job, or a very good job of making it extremely confusing to understand your plan benefits and utilize your benefits as little as possible. But I think, you know, obviously the ACO piece is a big change of that. You've got all the key stakeholders now are starting to get alignment around the right things, whether it's, you know, getting the right utilization of care and having that tied to a financial incentive that makes it worthwhile. But, you know, the old traditional fee-for-service model certainly unintentionally built up a very screwed up revenue model.
Do you want to add to that?
Oh, I'd love to. From the payer perspective, we get the data because the employers demand it. So that one becomes a little more straightforward when you have the employers at the table. We are finding that there are actually provider organizations that are reaching out to us to share their data. I think they're realizing that we are in a world of transparency, and they might as well play and help to shape it more. So, you know, whether it's providing quality data because they feel like they actually are doing well, or cost information, they want to be accurately represented. And so we are finding more progressive providers that are actually coming to us. And yeah, there are some that are still resistant.
Now, is that on the delivery side or on the physician side?
The distinction between, oh, you mean like a hospital
versus
a provider?
an IPA, yeah, physician.
We get both.
And are they generally the ones who come to you proactively, the most competitively priced in the market?
We do get a lot of the lower price providers who are coming to us, but we also get some of the higher price who believe they're higher quality.
Yeah.
And so, trying to find the balance. But because our application is also on, the smartphone, we're finding Microsoft employees taking it in and showing their doctors, and then doctors reaching out to us to work with us. So it's both the patients taking the information in, as well as those that read the press or whatever.
So moving to the next topic, this is a juicy one. You could talk about this one all day. I mean, honestly, I think it's interesting. The answer to the question was to save money, to improve their P&L, and for marketing purposes, which is the same answer. So in the end, the reason these guys want to share data is to make money, right? I mean, that's the only reason for them. So it's an interesting dynamic when you think about your applications and what you're building and the products that you're putting together. I mean, that is, money talks, right? So another question I have for you guys. Does anyone, and I'm talking about consumers now, do they care about confidentiality anymore? Because I see people putting all kinds of stuff on Facebook and in apps and leaving it on a table and, all over the place. And, it seems like consumers care a lot less about data confidentiality than the government may. And I'm wondering if that's true. Is confidentiality truly important to consumers anymore, and when? Jill, you have a thought on that?
I'll just, I think it is. And I think in particular, what people care a lot about is making the decision themselves about what to share. So in your example, that is their data, and if they want to leave it lying around, then they can, which is not the same as someone else sort of owning their data, not having explicit permission about how to use it, and selling it or repurposing it in all kinds of ways. So Patients Like Me, which is a portal where people they join voluntarily, include self-report data on things. They self-identify their condition, and they talk about what therapies they're taking and what side effects they're having, and join these online communities of people who have like conditions. And they do that voluntarily so that they can contribute information and share it, and they can learn from the experiences of others. But that's a really different model from there's all this data floating around and I don't know about or have any control over how it's being used. So I think that's a key distinction.
Anybody want to jump on that one?
It's something we think about a lot. As we have, this rich set of information, we are able to send alerts out to the users of our system, whether it's for a gap in care or some other information. We give them tips on their past care. And so really kind of carefully navigating that to make sure that we continue to be a trusted entity. And I think that's a key component of that. We're also now getting ready to roll out our own user review survey. And because we function in a relatively closed environment, one of the concerns is sort of the self-filtering that a user might do in describing their experience in seeing a particular doctor, that they might convey some information that would enable some of their peers at the employer to identify who they are. And are there sensitive conditions that we could screen out to at least sort of minimize the lack of filtering that some people may have? And it's a complex and challenging question because that information is also helpful to other users in better understanding that particular set of experiences.
Okay. And just one other quick point on that, because it really, I think, relates to the conference objective today, which is really about largely freeing the data and increasing the flow of data. And I think that while the government protections on the data are clearly very it's very important to have those privacy protections. They have, and many of you may have experienced this, put up very significant barriers that can really stop the flow of data cold. And certainly I have observed this in initiatives where you need to actually get multiple varieties of informed consent. People need to give you their social security number. They don't understand why they have to do that, but there's no general system of medical identification. So it is worth thinking about it also from the perspective of what is the minimum level of protection that's necessary to make sure that confidential data isn't misused, while also trading that off against the flow of data that can really open up some possibilities and improve potentially the data that are available, not just for consumer decision making, but also for quality improvement and for oversight and for many of the other purposes that I think we all share in terms of making the system work better.
So we have 5 minutes left. Does anybody have a question for somebody on the panel? No? Whoop, got one here.
Hi, I'm from Yolo County. I'm very interested in how you communicate data on, for example, these hospital data that we can get from the Office of Statewide Health Planning Development, also known as OSHPD, another acronym. And for example, I'll just use UC Davis Medical Center. They're a high-level trauma center, so the highest risk patients tend to go there for births, delivering babies, for specialty care, if there's been a traffic accident. And so the local community hospital might look better on some indicator, but you've got to realize, how do you communicate to patients that this hospital takes these high-risk cases? How do you communicate that? How do you communicate that in Richmond, where there's one part of Richmond has a very high number of African Americans, they're poor, they're in poverty, there's high rates of crime there. How do you communicate that the hospital that serves those patients, all those patients tend to go to one hospital, probably because they're mostly on Medi-Cal or Medicaid, and so maybe that hospital's indicators look really bad on some particular thing like asthma. So how do you communicate the differences in the underlying populations that are served by hospitals?
Anyone?
I mean, our focus is finding quality measures that have already been risk adjusted.
Right.
So
Okay.
to the extent that the methodologies exist to take those complex patients into account in coming up with the measure results.
So
Anybody else?
basically you're saying you risk adjust, which the consumer probably has no idea what that is, but I do as an epidemiologist. But if it's adjusted, then that seems reasonable to me.
Yes. The data that are reported publicly, certainly from government sponsors, are going to be risk adjusted.
Okay.
And we also, in order, again, to make it more consumable for the user, is we will take, like, we use the CMS Hospital Compare measures, and there are now a number that are reported that, bloodstream infections, hospital-acquired infections, events that occur during surgery that should never happen, things like, a wrong site surgery or something left in the body after surgery. And we put them into a composite measure so that helps to sort of, again, differentiate the variation between hospitals, but it's also, by having that higher level composite, something that a consumer can much better understand than how does this bloodstream infection that is, 1 in 1,000, really, what does that mean to me?
I think we have time for one quick last question if there is one, or else we'll wrap it up. Oh. Sold.
The low bidder. So on that issue of access to data versus privacy, can you talk a little bit about the distinction between access to the data for public purposes, reducing childhood obesity, health conditions, those kinds of issues, versus access to the data for private purposes, improving profit or reducing cost, for example?
Well,
Is there a particular aspect of that you're interested in?
thank you, Lisa. Big topic.
Well, I think that so much of the conversation earlier today was about broad public policy discussion and how do you actually create access to the data in ways that can shape decisions around, food, access to food, right? But the nature of this panel is different in that you're dealing more in the private sector side of the market. So to the extent that we're putting together rules around access to data, trying to think about whether or not the rules should treat the public sector differently than the private sector.
Well, maybe I'll jump in, because I actually disagree with you. This is about the private sector. I mean, these vendors, happen to deal more with the private sector, but I think fundamentally the same issues exist in the public sector for the patient population there. They want to know who's a good provider. They want to know how to save money. They want to know how to take better care of themselves. So I think fundamentally the issues are the same. It really becomes down to an issue of big data applications for population management and for setting public policy and for understanding how to set the stage to change community behavior, as opposed to the data you deliver to individuals so they can help themselves in this moment when they're having a crisis or need help or trying to make their diabetes more in control or what have you.
I guess I would slice that differently.
Okay, then.
I would say that in the big data and the little data, there's a role for the public sector and the private sector, and the challenge of policy is to leverage the relationship between the two. So in the context of that leveraging, should the standards around sharing personal data be different if it's a public purpose controlled by the public sector versus the private sector? I'm not saying they are. I'm asking the question of folks who
I
have some
can tell
background
you
on
with
this.
the reform language that with the new exchanges, there are a litany of new data reports that payers will be submitting back to HHS on a frequent basis regarding their specific population and how those members are, what their conditions are, where they're going for treatment, what the claims experience is, what the medical loss ratio is, there's a ton of data that will be that's newly enforced that payers will be sending to HHS, and I think HHS is, I commend them for what they did with the hospital pricing. They're going to be taking that data and they're going to, I think, continue to iterate on providing hopefully more digestible forms of how things are going.
I think we're out of our time, so thank you very much for your attention. Thank you, guys.